Hello, good evening everyone. Welcome to the Eurogen webinar series. I'm Michelle Batty, I'm the manager of the Eurogen network. I just wanted to take a couple of minutes to explain a little bit about the European reference network that we call Eurogen. It's one of 24 European reference networks that were created by the European Commission in 2017, covering most medical disciplines. And what we do is we aim to deliver quicker specialist evaluation and more equitable access to high quality diagnosis, treatment and care for patients with a rare urorectogenital disease or a complex condition who need highly specialised surgery. And some of our activities, well, we run virtual consultations, so a multidisciplinary team of our experts can diagnose, suggest treatment options or different surgical approaches, or suggest post-operative or transitional support. We do this using a secure web-based IT platform called the Clinical Patient Management System, which was kindly funded by the European Commission. We also collaborate on training and education activities. This webinar program is an example, training courses, and also an exchange program of healthcare professionals in our healthcare provider members. And then the other thing that we've got going on this year, it's quite a lot, is we're developing a Eurogen patient registry. So we're hoping that contributions from many of our clinical teams will really help to provide the evidence base for future research and clinical guidelines. So that's just a little bit about the network. If you want to know more, please visit our website. But now I'd like to hand over to Hans Langenhausen. It's Hans' second time back here for the Eurogen webinar program, so thank you so much for that, Hans. And he's a consultant urologist at Radboud University Medical Center in the Netherlands, and his speciality is minimally invasive surgery for kidney and adrenal diseases. His research activities focus on perioperative imaging techniques and adrenal surgery and innovations in minimally invasive surgery. He's a faculty member of the ESU and is attending the annual EAU Congress, and we all hope, I think, that that one will be back on again next year. That would be nice. And finally, and of course it's very important to us, he's the work stream leader for rare urogenital diseases for our network. So Hans, thank you so much for coming back here a second time, and it's with a lot of pleasure that I give the floor to you. Thank you.
Well, good night, everyone. Thanks for joining this webinar of Eurogen Workstream 3. I'll have a talk tonight about adrenal cancer and specifically the role of laparoscopy in adrenal cancer. Thanks for joining. I'll start my presentation. I have no conflicts of interest with some knowledge about ACC, adrenocortical carcinoma. Next step will be how to diagnose the disease and different surgical approaches available and the role of laparoscopy, and then some future developments for the disease to come to my conclusions at the end. So first of all, adrenocortical carcinoma, as you may know, is a very rare disease. There's an estimated incidence of about 1 per million people, and there's a slight predominance for female patients. It's a very aggressive disease with a poor 5-year survival rate of maximum 47%. And historically, open surgery has always been the gold standard, as most of these tumors are large. There's a median size of 10 to 11 centimeters, and over 90% are over 6 centimeters. So large tumors, open surgery. So you have to realize that ACC is relatively insensitive for chemotherapy. So the only chance for cure, and the only good chance for treatment is surgery. So the first operation is the most important one and should be a oncologically perfect operation without any positive margins. So we have few data of this disease because it's so rare, so we have to deal with consensus meetings, as you can see on the slide here, and deal with systematic reviews and meta-analysis. How to diagnose the patient? The patient sometimes presents with hormonal overproduction. This is mostly cortisol producing adrenal cancer, and as you know, cortisol will cause the disease of Cushing and high blood pressure, and quite often ACC produces androgens, which leads to virilization of the patient, or even estrogens leading to feminization. There could be a local mass effect like flank pain, nausea or vomiting, and patients quite often have weight loss. And it could also be that you incidentally find an adrenal cancer. So be aware of a genetic context. There are inherited cancer syndromes like Li-Fraumeni or Lynch syndrome, which have a higher chance of ACC development, and the same counts for MEN syndrome, in which there are multiple endocrine tumors in different endocrine organs. So adrenal cancer is staged according to NSAID classification. This is the European Network for the Study of Adrenal Tumors. And basically NSAID stage 1 and 2 ACCs are localized tumors below 5 centimeters, or stage 2 over 5 centimeters in diameter. All other tumors, stage 3, are locally advanced, either T3 or T4, or have positive lymph nodes. And stage 4 NSAID classification are metastasized patients. So let me tell you about diagnosing the disease. So I already said that a biochemical assessment is really important. First of all, you got to exclude pheochromocytoma, which is an adrenal adrenaline producing tumor from the medulla, and this could be a lookalike on imaging of ACC, so it's really important to exclude pheochromocytoma before you start to operate, because these adrenalines can produce very high blood pressure intraoperatively if you don't find this beforehand. So first of all, exclude pheochromocytoma and then assess for cortisol production, which is often the case in ACC, which is also a bad prognostic factor in this disease. And then, as I mentioned, you could assess for androgen production or even steroid precursors. And second, imaging is the important step to do. You should do a thoracoabdominal CT scan with a non-enhanced phase and IV contrast phase. So these tumors have a very heterogeneous appearance. You see sometimes necrotic parts centrally in the tumor, or even hemorrhage, and this is on the non-enhanced phase. And the Hounsfield units on this phase are relatively high, so over 10. Then after giving IV contrast, there is a typical peripheral enhancement of the tumor, and again you see quite often central necrosis. So after giving contrast, the washout of contrast is low, especially the absolute washout after 15 minutes is below 60%. And quite a few of these patients show a vascular invasion, could be either the adrenal vein, the renal vein, or the inferior caval vein, about 20% of the cases. About a third of patients present to you with synchronous metastases. And you could also do MRI for diagnostics. It's not better than CT scan. So CT scan is still the standard, but especially for venous invasion, the MRI performs a little bit better than the CT scan. So if you're specifically interested in venous invasion or caval thrombus invasion, then you might consider doing MRI. Then the role of FDG PET, there's the problem of a lower specificity of this imaging modality. So you can see FDG uptake in pheochromocytomas as well, but also in adenomas. So there's a slight problem for the disease. So we don't use it in first instance, but we mainly use FDG PET for staging to find metastasis. So if you have uptake in the primary tumor, you will expect uptake of FDG in the distal metastasis as well. And we use it for follow-up. So if you have an incidentaloma, so an incidental finding of a tumor, we do the same. We assess the radiological appearance and we assess for hormone overproduction. And then there is this size issue. As you may know, smaller tumors below 4 centimeters diameter, there's a very low chance of being an adrenal cancer. When the tumor is over 6 centimeters, the chance is significantly higher. And there's sort of this gray area between 4 and 6 centimeters where you just don't know. There's not so high chance for malignancy, but we don't know. And this is specifically the gray area that we talk about because these are small tumors. If you would go for open surgery in all of these patients, of which only a few have an adrenal cancer, you do a lot of very invasive surgery, which is not beneficial to the patient. And most of the times it's a benign tumor. So it's more attractive to do laparoscopy in these patients, and I'll discuss later whether this is feasible or not. Just to show you a follow-up scheme that we use for these incidentalomas. So you have a tumor that is over 4 centimeters in diameter, or there's an uncertainty in imaging, whether it's benign or not. Well, discuss it in your multidisciplinary team and then consider immediate surgery, or if it's not that suspicious, you can consider follow-up as well by doing another non-enhanced CT scan after 6 to 12 months, or do immediate further imaging with a CT scan with IV contrast or FDG PET to show you whether it's suspicious enough to go to the operating theater straight away. If you choose for follow-up after 6 to 12 months and there's growth, significant growth, you have to reconsider surgery again. Otherwise, if there's not, you could do another follow-up scan after 12 months, and then after 2 years maximum without any growth, you can consider stop follow-up. So I brought you 2 cases tonight. The first case is of a 60 years old female patient that we saw in October last year. She presented to us with abdominal pain complaints. She had weight loss, significant weight loss, and she lost her appetite. So we did imaging with CT scan and biochemical screening. We excluded a pheochromocytoma, so there were normal metanephrines in this patient and also normal cortisol values. But indeed, the androgens, as you can see here, were raised. And on thoracoabdominal CT scan, we saw a large adrenal tumor on the left side. And we also performed FDG PET for staging this patient. So here are the images of the CT scan, the upper row. So as you can see, it's quite a large tumor in the left adrenal. It's about 15 centimeters in diameter. And as you can see here on the second slice of the CT scan, it has this typical heterogeneous aspect. This is the contrast phase scan, but you see this aspect of central necrosis. And on the third slide of the CT scan, this typical peripheral rim enhancement. And we also had a suspicion of either ingrowth in the left kidney or at least a displacement of the left kidney. And then at the bottom of this slide, you can see the FDG PET image. There's clear enhancement of the tumor. And as you can see on the CT scan as well, you see it on this FDG PET images that there is this central necrotic part, which is quite typical for ACC. The second case I would like to present to you is a much younger 32-year-old female patient who came to our expertise center in 2017. She had an incidentalloma in the right adrenal. She initially presented in another hospital with flank pain, and they found a adrenal tumor over there of 35 millimeters. Decided to do follow-up, and follow-up scan after 6 months showed a significant growth up to 47 millimeters, and patient was referred to us. We did another thoracoabdominal CT scan, and we found quite a high Hounsfield units in the non-contrast phase of 31. And after contrast, there was a very slow washout of 28%. So this patient was hormonally screened as well. There was no hormonal overproduction of the tumor. I'll show you in the later slides what we did with these two cases. So first, I would like to discuss with you what are the surgical approaches for adrenal cancer. And well, you can say, and we discussed this in the consensus meeting a few years ago, which was published in 2017, that in general, obviously surgeons, the training and volume have positive effects on morbidity, on mortality, and also on overall survival. This counts for ACC as well. If you look at ACC treatment in referral centers, we know that surgeons with high caseloads have a better chance of a negative resection margin. And also, it appears that dedicated multidisciplinary teams have a positive outcome for the patient as well, although clear overall survival improvement has never been proven. And then what is high volume? We discussed that in the consensus meeting and found that you should do at least 15 adrenal operations per year in a referral center. And you should have expertise in both open and laparoscopic adrenal surgery. And you need expertise in your hospital in vascular, in liver, and in pancreas surgery as well. We also found that preoperative multidisciplinary discussion is commended in expert centers. So we know from adrenal cancer that intraoperative tumor spill or macroscopic positive resection margin is really a bad development and leads to very high recurrence rates and a poor survival. So this is the basis of adrenal cancer surgery. Do it in a proper way, do it radical, and any tumor spillage is a disaster for the patient. As you can see on the slide, in 5-year survival rates, if there's a negative resection margin, it's about 50%. But if you have a microscopic positive resection margin, it drops to 20%. And when it's macroscopic positive margin, it drops to 15%. So surgery is really the key for cure in adrenal cancer. And there's quite some conflicting reports about laparoscopy in literature. Obviously, there are no randomized trials comparing open surgery and laparoscopy for adrenal cancer. So this is all based on retrospective series and expert opinion, and no long-term follow-up in literature. And the laparoscopic series are often of low numbers and low quality as well. But there are some concerns in literature about tumor rupture, about carcinosis of the peritoneum and local recurrences. But until now, there's no clear proof that overall survival is conflicted in laparoscopy compared to open surgery. So there's definitely concern about laparoscopy in this disease, but should we really abandon it, or is there still a place for laparoscopy? So if you look at the principles of oncological surgery, these should be followed in open surgery, but also in laparoscopy. So this means that you should do a proper en bloc resection of the adrenal tumor, meaning that you take out the tumor, including the periadrenal fat. And the main reason is that about a third of these patients who are supposed to have a localized tumor, stage 2, in fact have a stage 3 infiltrating tumor. So they are being upstaged after surgery. That's why you should do a radical en bloc resection. Second, lymphadenectomy is important mainly for staging reasons. You should take out the lymph nodes in the renal hilum. There's no clear evidence that survival improves, but it may have an effect in patients with positive nodes on local recurrence rates. And obviously, you should do an immediate conversion when necessary, meaning that if there's any doubt about surgical margins, about being radical, then you should easily convert to open surgery. So in this consensus meeting we discussed, and we found it feasible and safe only for localized adrenal cancer, so end stage 1 and 2, below 6 centimeters, to do laparoscopy, and obviously in experienced hands, so surgeons who do at least 15 procedures per year in expert centers with multidisciplinary approach. And then the technique, the transabdominal approach is considered the standard for adrenal cancer surgery. Why? Because there's less experience in retroperitoneal approach. The assessment of metastasis might be better by going through a transabdominal approach. And you have more workspace. It's easier to do a en bloc resection by this approach. But until now, there's no clear evidence in literature that it's superior to retroperitoneal surgery. My personal opinion is that it's in fact probably the best way to go by transabdominal approach, and don't do retroperitoneal approach in adrenal cancer. Any other tumors, so ends at stage 3, tumors that show invasion on preoperative CT scan, or there's a suspicion of positive lymph nodes, you should go by open procedure. And also for local recurrences, so after surgery, there's about 60% chance that there will be a local recurrence. Open surgery is recommended, and you should not do laparoscopy, especially when you consider that doing a good operation by having a negative margin of this local recurrence, it still benefits the survival of the patient. So let's get back to the 2 cases I showed you. The first patient was a 60-year-old female patient with a large tumor in the left adrenal. We did an immediate open resection of this tumor and took out the adrenal tumor, including the kidney, en bloc, because we had suspicion of ingrowth, and we took out all the hilar lymph nodes as well. This was slightly complicated, this operation, by a small tear in the diaphragm, but this was sutured, and eventually the patient recovered from this. So our pathologist, he reported that it was in fact an adrenal cancer of 15 centimeters diameter. It was stage 2 because there was no invasion. So in the end, there was a displacement of the kidney, but no invasion of the organ. And there were no positive lymph nodes found in the resection. The resection margin was negative. And the Ki-67, which is a proliferation protein for mitosis, was relatively low, below 10%, meaning that this patient didn't get any adjuvant treatment with Mitotane. So this is only recent, 8 months ago, and until now the patient has no evidence of recurrence of disease. The other patient was the younger patient of 32 with the incidence loma on the right-hand side. We did a laparoscopic adrenalectomy in this patient, and our pathologist reported an ACC of finally 6 centimeters, so end-stage stage 2. There was a negative resection margin in this patient, but a relatively aggressive disease. The WISE score is one of the ways to score adrenal cancers, goes up to 10, so it was quite a high WISE score, and the mitose index was quite high as well. So in this patient, it was decided to treat her with adjuvant mitotane. And until now, it's about 3.5 years follow-up. There's no evidence of disease so far. So what about the future? What are developments on surgical aspects of adrenal cancer? There's obviously robotics. We know all the advantages of robotics. You have your articulating instruments, a lot of angles of freedom, dexterity, and your enhanced image. So it definitely could have a place in complex adrenal tumors. In fact, the earliest reports were from the end of the 90s from Belgium, where a prototype of the robot system was used for the first time in adrenal surgery. And in the early 21st century, the Da Vinci platform was used for the first time in adrenal surgery as well. So this was not specifically for adrenal cancer, but adrenals in general. And since then, in fact, only a few reports, it's about 40 to 50 reports in literature are published about the use of robotics in adrenal surgery, and even less in ACC specifically. So it means that although the robotic platform is obviously very popular, it's not that popular in adrenal surgery. And the real question is whether it has advantages. In my personal opinion, it could have a role for complex, large tumors. But then again, as I said, the operation should be very radical. And there's always a discussion on whether you compromise margins by introducing a new device in such surgery. So the discussion is not closed yet, and will go on. And I definitely think that it could be discussed in a European context, as we might be able to get bigger numbers and to compare different surgical techniques, for instance, robotic surgery and laparoscopy, or even with open surgery if we get larger patient numbers. Obviously, there's always the discussion about costs. There are even studies showing that laparoscopy might in fact be superior to robotic surgery, but at the end, it always comes down to costs, and obviously these are a problem in robotic surgery. So as long as we don't have clear proof that robotics are better than laparoscopy in adrenal cancer, I think it will not be the standard. And until now, we only have an indication for laparoscopy in the smaller localized tumors. So this discussion is going on, and hopefully we'll learn more about this in the near future. So to conclude my presentation of tonight, the multidisciplinary team, as I like to stress, is a key in treatment of ACC. The assessment of hormone production and radiological assessment is really important. The laparoscopy should be reserved for small localized tumors, so below 6 centimeters. And in my opinion, and the consensus meetings as well, should not be abandoned in the ACC, but should be performed by expert surgeons in reference centers. So open surgery still remains the standard for every other suspected ACC tumor, and there's future developments that should, in fact, could be discussed in a European context and maybe help us to learn more about different operating techniques and the use of them in ACC surgery. So thank you very much for your attention. If you have any questions, please feel free to ask them. Thank you.
Hi everyone, so yeah, that's the end of the presentation. So thank you to Hans for doing that. Hans, if you could put your video feed on, that would be great. So just waiting for questions to come through. So if you've got any questions, please ask them now. Hans is available to answer anything for a few minutes yet. Hopefully everyone can see that okay. I know one person couldn't see the video, so I'm presuming everybody else could. No one said anything. If any problems, of course, just to say we do record all of this, so it will be available later in case anybody missed anything. I'm also aware, in case anybody maybe joined late, possibly there was some issues with that occasionally with them going to the start of the video rather than joining midway through. But it will all be available on both our GoToWebinar platform and our YouTube channel afterwards from tomorrow. The edited version will be available on there. Yeah, so thank you, Hans, for doing that. We haven't got any questions at the moment, so as I said, this sometimes happens. But of course, there are things, any questions afterwards. So if you want to maybe rewatch the material, you can also send questions to me. I'll pass them on later. We'll also be sending out a survey tomorrow to everyone, everyone who's attended today. We're really grateful if you can fill that in as well. It's really helpful for us to help improve future sessions. So we'll ask you some technical things around the sound, things like that, but also kind of the content as well. So any feedback would be great. So got one question come in while I'm answering. I'll send it on to you now, Hans. Hopefully you're able to see that. You should see a questions tab appear. You can move it out using the grey button, on the right.
Thank you, Darren. So there is one question of Luca Benisic is asking what my diameter cutoff is for open surgery. So thank you for this question, Luca. As I mentioned, we had this consensus meeting, which was back in 2014 with more than 20 European experts from the field, both endocrine surgeons and urologists. And we had an extensive discussion in this expert meeting about diameter issue. And at the end, in the Delphi method, we found consensus to do laparoscopy up to 6 centimeters maximum, and over 6 centimeters do open surgery. So in my opinion, that is a wise cutoff. As you may know, it might be tempting to do laparoscopy in 7 or 8 centimeters diameter, but I tend to advise to do open surgery in those cases and stick to the 6 centimeter diameter cutoff. And as I mentioned in my presentation as well, you have this gray area, this 4 to 6 centimeter diameter. You get quite a lot of these patients with unknown adrenal tumor, which might be an ACC, but you're not sure. And if you would do open surgery in all these cases, that would mean a lot of burden to society and to the patient as well by this open surgery. So I think definitely in that gray area, 4 to 6 centimeter, there's a role for laparoscopy.
Okay, as any follow-up to any of that? Yeah, Lucas says thank you for the answer, Hans. We haven't got any other questions yet, so let's give everyone a minute just to want to ask anything. Otherwise, we can leave it there. So again, thank you to everyone who attended today. Just to carry on what I was saying previously, I guess you can look at it. Please check out our website to look at other forthcoming webinars. We've got some more planned for another one for May, 2 in June, 2 in July, details of which, some of which need to go on the website still. We're taking a break in August, as we do every year, and then back in September. So we're aiming for 2 a month regularly from now on. Please also, yeah, if you kind of want to watch this back tomorrow on our YouTube channel, please also subscribe to that as well. That will, you'll be notified then of any other forthcoming videos we put on there. We've had quite a lot of subscribers recently, so it'd be great if you could join us as well. Okay, so yeah, no other questions, Hans. So of course, people asking it later on, I'll pass it on to you. But thank you very much for doing today's presentation. Your second one went very well, I thought. So thank you, and thank you to everyone who attended. And we'll see you hopefully for our next webinar on the 25th, I think. It will be 25th of May. So hoping to catch some of you then. Thank you very much indeed. Goodbye all.
Thank you. Thank you. Bye bye.